Good evening, everyone. Welcome to this session on ward rounds. Now, as we mentioned previously, ward rounds is one of the classical, conventional teaching tools. And as I again mentioned in one of the previous classes, every tool has a specific purpose. The purpose of ward rounds is to learn and educate ourselves about how we deal with the patients in the wards. And if you look at a practical sense, there are only two situations where you would spend your time with the patient on the ward. It's an extremely important time. In fact, the results of your operation, however good you are at doing the operation in the operation theater, the results will depend on how good your work in the ward is. And this may be pre-op and post-op. So ward rounds includes both, but most of the time we worry or focus on the post-op ward rounds. Whereas the pre-op ward round also is equally important, because in the outpatients, you really do not spend the kind of time and the studying the patient, at the kind of depth and detail that you really should. You may not have the time in the outpatients department. So more like screening, you decide what are the tests to be done, look at the tests perfunctorily, and perhaps decide that the person needs surgery and then put him in. And it is the resident or the junior doctors, including, of course, the consultant, who has to go through these things in detail uh, when the patient is admitted to the ward, and then make sure that the right decision has been taken in terms of offering the surgery, the right kind of surgery, and the right kind of workup has been done. So that is a very important part of ward rounds that in the academic part of it usually gets discussed during case discussion, during clinicals. So even though that's a part of ward rounds, what we discuss usually in the teaching exercise, in the academic part of ward rounds, is the post-op care. And that can again be of two further kinds. One would be a general kind. What are the things that you generally look for in all surgical patients? And there would be a specific kind where you would focus on certain aspects for a given operation or a given condition. So today we are going to talk about the general things that we look at when we do an operation. This is like a group discussion. So it's going to be very simple. There are no tricks. Most of it we know already. So it will be a revision for most of us. But for the beginners, the first years, it would be, I think, very helpful to understand what is looked at in the classical post-op care of a patient. Okay, so what we are going to do is ask you a very simple thing. You take a round the day after 3 or 4 operations have been done in your unit, and you're a first-year resident. What are the warning signs that you're looking for in a given patient? First post-op day, next morning. Praveen.
Good evening, sir.
Good evening.
Sir, should check for the vitals of the patient, sir.
Explain each one of them.
Sir, pulse rate, BP, saturation, respiratory rate, temperature of the patient, sir.
All right. Is there something that you're left out? Nikita.
Sir, I think that is all, sir, mostly.
That is all. What do you understand by the term facies or general demeanor?
Oh, the general condition of the patient,
Yeah.
how he's like comfortable or tired or
Yes.
drowsy.
Is he cheerful? Is he conscious? Is he oriented? Please do not underestimate the value of the general demeanor. Okay, and the level of consciousness. Is he confused? Does he know where he is? Is he comfortable? Does he look uncomfortable to you? Does he look as if he's suffering? please one look at the face, and as you, particularly as you gain experience as a surgeon, really when you walk into the ward the next morning, when you look at the person from a distance, you can say that everything is okay or that there is something not okay. All right, that's a very important thing that you must first look at. We do that, but we don't sort of give particular attention, and when we list things like we did just now, that tends to get left out. You mentioned each one of these things, which are again very important. I agree. So what are the sort of cutoffs that you would think? You said pulse rate. For each of these parameters, what are the cutoffs? Praveen, again.
Sir, uh,
What is a
pulse rate,
figure? What is a pulse rate that would make your antenna go up?
sir, normal pulse rate
I'll-
60 to 100,
No,
sir.
no, just I want
Sir,
the
range,
extremes. I have already given you the answer there.
sir, greater than 100 and less than 55.
Yeah. So what would you say that about the other parameters? Temperature,
Uh,
blood
About
pressure.
temperature about 99 degrees Fahrenheit.
Okay.
Uh,
I would say
blood
100 degrees Fahrenheit.
100.
Because, yeah,
Yes.
99, everybody will be a
100.
little febrile. Okay.
Blood pressure over 140 by 80, sir.
I don't want the
40,
normals
90.
here.
Sir,
I'm telling you what are the cutoffs? What are the things that will make your antenna go up? Why am I concerned about everything being normal? I want to know, when is it that my antenna will go up? You know what I mean by that? When I wake
yes,
up and say, look, there is something wrong, let me look into it further. So what are those figures?
blood pressure 160 by 90, sir.
Okay.
More
if
than
it's-
160 by 90.
No, I want,
Sir,
are you very worried about the diastolic pressure when you walk
no,
in?
sir.
No. So
No, sir. Majorly
systolic.
systolic pressure, sir.
Yeah. So what are the things?
One,
Okay. I mean,
greater than 180.
these are not sacrosanct, but approximately I'm saying. Okay. Okay.
Yes, sir.
And so you need to worry if that is the range for your blood pressure. If it's less than 100, you should worry about it. What else? Respiratory rate. Keep
More
talking.
than 30, sir.
Okay. 30, I
20.
think, is very high. Okay. More than 20 or less than
20.
10. And SpO2, as the thing says.
Less than 90.
On room air, on oxygen.
On oxygen, less than 80, sir.
On room air itself, if somebody's
sir.
saturation is less than 90 on room air, I think you're right. These are ballpark figures. Okay. And urine output less than 30 ml per
30
hour.
ml per hour.
Okay. So
Yes.
you know about this, the news. What is the news? I'm giving you the answer. What is the news? Now, these are ballpark figures, but you can be a lot more accurate with it. Right. So what is news? What is EWS? Nikita.
Sir,
Pawan will know. That is his research project for this time. Pawan.
Early warning signs, sir.
Early warning signs. There are several scores of early warning scores. Early warning scores. Okay. And the one that is generally being used in the UK is the National Early Warning Score. And that is the news. Okay. And this is what it is. So you can see from this that you have several factors. Okay. Nothing different from what we have already mentioned. Okay. Respiratory rate, oxygen saturation, supplemental oxygen given or not, temperature, systolic pressure. So you don't say 160 by 90. More, worry more about systolic pressure, heart rate, that is the pulse rate, and the level of consciousness. So you can give a score. 1 is normal. 1, you give scores above and below this normal range. And if you find that the score is more than 4, okay, aggregate of 5 or 6, excuse me, it is a mild or a medium kind of situation. And if the score is more than 7, your antenna must really go up. So when the antenna goes up, what do? Suppose somebody's news score is 7 on your next ward round. What do? Go on, Praveen.
Sir, we should check what are the parameters that are deranged, and we
Yeah.
should take necessary steps to
What
bring
is
it
the
to the
first
normal
thing that you
limits,
do?
sir.
Do you think this patient should be looked after in the ward or elsewhere?
If it is high clinical risk, he must be shifted to the.
That's all. I did tell you, what would you do if the score is more than 7?
He
Shift
should
them
be
to a
shifted to the ICU,
HDU.
sir.
Yeah, ICU.
ICU.
If you have an HDU, that is the first step that you take as a resident, and inform your seniors.
Yes, sir.
And in that situation, with a heightened level of nursing and monitoring, you will look after the patient. You
Yes, sir.
understand that this is not just theory. It is an extremely important thing when you do the morning rounds the day after surgery, or even subsequent days as well, when you're looking after a post-operative patient. These are the things that you must focus on.
Yes, sir.
Okay. Questions, comments? All right. So, as you said, okay, there's a comment from Ravi Shankar. Nutritional assessment, psychological assessment, and counseling and evaluation of other comorbidities form the pre-op ward round. Fair enough. Pre-op ward round, as I said, yeah. Our focus has been on the post-op ward round this time, and quite right that these are the things that need to be focused on before you take the patient to surgery. Okay. Now, Nikita, what would be the documentation that you would do? You might have done the best post-op round, but unless it is documented, it's not done as far as, the
Yes,
world is concerned, as far as the courts are concerned, for example. So what is the documentation that you do?
sir. We initially start from the date and time of the documentation and the person who is seeing the patient.
Mhm.
And then we go for the uh, general general assessments, the general demeanor of the first line. Um,
How do you organize your
so
documentation? You have so many of these things. How do you organize your documentation?
in the order of SOAP regimen, sir.
Correct?
Subjective, objective, and
Yeah.
assessment and I
Plan.
forgot P, sir.
Plan.
Planning, yes, sir. Yes,
Good.
sir. Advice.
Yeah. So what would you write in the subjective area?
So what he complains, sir, whether he is feeling well or he has some pain or any other
All right.
complaints he has.
Objective.
That comes objective. The his intake and output.
What you make of it?
Regarding.
All the parameters that we mentioned.
Yes, sir.
And a few more. Okay.
And the assessment.
Yeah. So that is what you do. And once you write the subjective and objective findings, what does the assessment actually mean?
Assessment means what we
what you think
derive
of the
from
whole
the
thing.
parameters. Yes, sir.
What you think of the whole thing. You put together his subjective complaints, add to that your objective findings, and between the two, you decide which of those symptoms that he complains of need attention, which of those are probably not that important, and then you write an assessment. And then
Yes,
having
sir.
done that, you detail the
Plan.
plan. What is it that you're doing having done this assessment? So you understand that you assess objectively the problem, mention a differential diagnosis. As I mentioned yesterday, there's always a differential that you must entertain. Don't ever fixate yourself on one diagnosis, because as the situation unfolds, you may be surprised if you have just one diagnosis in mind. And then you write what are the actions you take in terms of taking help, informing the seniors, even that has to be mentioned, taking advice, asking for investigations, and having a treatment plan. What is it that you do? That is the SOAP regimen. And that, I think, is an important thing that you need to have. All right. So, Vinod, summarize what we have said so far as a revision for all of us.
Yes, sir. Generally, once we go to the patient, we have to see the general condition of the patient and then general examination, and we have to document the data basing on the SOAP regimen. We'll start with the subjective complaints, and our generalized examination, and then we'll come to the conclusion, what is the diagnosis of the present day, and then go for the plan for the day.
Right. So when you write a set of investigations, would you actually get it done, or would you do something else before you actually get it done?
I didn't get, sir. Sorry.
You said in your plan of action
Yes, sir.
that you would write or ask for some investigations based on the patient's condition.
Yes, sir.
You would also write a treatment plan, some medication, maybe analgesic, maybe antibiotic, maybe this, maybe that. Now, would you actually carry it out, or would you do something else as a resident?
I'll
As
inform
a, yeah. So what you have to do is that this is a provisional plan of action. And the actual action will be taken either by the registrar, or he may choose to escalate it to the consultant. And at the end of the day, the order for actually doing something must come from the consultant. All right. That is something that you must understand. So when we talk about the general things, we also mentioned about the temperature. Now, let us think of a situation when you're writing it down. The patient is febrile, has a fever of 101. Okay. Indraja there?
Yes,
So
sir.
what is your understanding of the post-op fever status as far as the chronology or the days from the operation is concerned? If any of you attended the RRC, I mean, not the Hanumaya lecture, this would be a repetition for you because many of the slides are the same. But I didn't cover even 20% of what I'm going to cover today. But it's good. It doesn't matter even if you, as long as you know, understand what we have been conveying, that's all I need. So in a temperature,
Yes, sir.
tell me, what
If
you see a temperature of 100.8 on first day. What does it mean to you?
Sir, any ongoing like ongoing blood loss or anything?
Blood loss gives you temperature?
No, sir.
I would expect tachycardia and perhaps
There.
a fall in blood pressure.
Yes.
Okay. This is a very fundamental thing, Indraja. Pawan,
Yes.
you want to have a go?
Sir, day one, any atelectasis
Yes.
and any hospital acquired infections like urinary tract infections.
Day one may be too early unless the patient was in hospital for a long time. Pyrogens in IV fluids,
Yes, sir.
atelectasis, they stand out. These are not the only ones, but these are the important ones. What happens if it is on day 3?
Wound infection, sir.
All right. It may be a little early, but anyway, it could happen. Yes. Anything else?
Pneumonia, sir.
Yes. Full-fledged pneumonia versus the atelectasis of day 1. Okay.
And urinary tract infection.
Urinary infection can occur. What happens if it's
Any,
day 5?
Sir, day 5 means any, have to think about DVT kind of thing.
Yes, correct. Nikita, you want to add anything to it?
And
See, these things must just, you must be blurting these things out as a third year.
sir,
Okay.
sir,
Remember,
in case of any,
no,
Yes,
you
sir.
didn't blurt out, so you lost your chance, Pawan. It should just come automatically. Okay, the so-called 5 Ws.
5
Remember
Ws.
that. Okay. Just hold on. Yeah. Okay. On day 1, it would be your atelectasis and pyrogens. Water, day 2 to 3, urinary tract infections, particularly if you have catheterized them. Day 3 to 7, wound infection, UTI continues, but you'll also have a dehiscence, okay? Anastomotic dehiscence if you have one. And if the patient is in hospital, even with prophylaxis, please remember that if they develop a fever, day 5 to 7, you're thinking about a DVT. And of course, a wound dehiscence. Remember, wound dehiscence is in the anastomosis is an anastomotic leak. It is not only day 3 to 7. It can occur a little bit later also. Remember that. But first, the basic thing that you have is, if classic situation is anastomotic dehiscence day 5. And if the thing is going on for a long time, then it means that you have a drug fever, and it could be the continuation of other things as well. Okay. So when you have a fever, the chronological occurrence of that fever is of importance. Okay. Now, we talked about the general demeanor and the temperature. Now, we also talked about the pulse. Between the pulse and the blood pressure, what is more important for you? Nikita?
Sir, I would go with the pulse, sir.
Yeah. Why would that be? You're right.
Significant indication of the hemorrhagic,
Not necessarily hemorrhage. Infection also can give rise to
infection. Yes, sir.
anything. Infection, hypovolemia. The point is the pulse
It's more
rate.
sensitive.
Yes, that is the word. The pulse
Yes.
rate reacts to these events in the body much faster than the blood pressure. So if you wait for the blood pressure to fall, okay, then you have left it for too late. So if you see a patient with a pulse rate of 110 and a BP of 140 by 90, 140 by 80, do not be happy. You must wonder why the pulse is 110. If it's 120 or 30, then that really is very serious. So pulse is a lot more sensitive, and that is what you need to do. Now, what we only talked about systolic pressure. When do you think the diastolic pressure also becomes important? Suppose the patient has a systolic of 100, a pulse of 110, and a diastolic of 60. What does it signify? In the blood pressure, there are two things that you have to focus on. One of them is this. So if you have a blood pressure of 100 by 60 or 50, what does it mean? Pawan? What is that situation called when there is a difference between the systolic and diastolic is higher than usual? What is that pressure called? What is that parameter called?
So pulse pressure.
Pulse pressure. So if the pulse pressure is wide, what does it signify? Hypovolemia.
Hypovolemia, sir. Yes.
Okay.
Yes.
There is another way of determining if the patient is hypovolemic in a patient who is hypotensive. Another simple way of detecting whether he is really hypovolemic. What is that method, which you can employ everywhere, in the emergency department, in the wards, everywhere? Nikita?
Skin turgor, sir, like
No.
dehydration.
No.
Urine output, sir.
No. Just the pressure. No other
Capillary
parameter.
Just the pressure on the pulse, sir. The
No.
character of the pulse.
The
Sir.
simple answer is orthostatic hypotension. Patient is flat. You measure a systolic of 100 and you make him sit up and measure the pulse, the blood pressure. Systolic becomes 80. Okay. Any fall in the systolic pressure of more than 10 millimeters of mercury, when you shift the patient from a supine to a sitting position, that is an indication of hypovolemia. It is something which people do not use but should be using regularly for you to get a handle on whether somebody is hypovolemic or not, because that is when you give a rush of, say, Ringer's lactate or any other crystalloid, a liter of it, maybe even 2 liters if required, and then you will get the patient well hydrated or well filled. Okay. And respiratory rate. We have mentioned about the thing, and going with it is the oxygen saturation. All right. So you must check this. This is a summary of what you need to do. And this is not just theory. Every single patient that you see on the ward, you must do this. When you document it, you don't have to necessarily write every one of them down because these things will be in the nurse's chart. But you must say that you have checked all these things and that they are normal. And if there's something abnormal, of course, you have to document it. Okay. And we next come to a chest examination. We were only concerned about the vitals so far. And then as you know, if the consciousness is not very good, then you have to do a neurological examination. That goes unsaid. But before we go into the cardiovascular system, the neurological systems and the like, there are two things that you normally do. A chest examination on every patient and an abdominal examination, particularly if he has had an abdominal operation. All right. So going to you, Indraja, again, what would you check? Do you really actually auscultate every patient that you see on a morning round? Tell me honestly.
No, sir.
You should. Okay. As a resident, every one of you must auscultate and check that the patient's chest, air entry, quality of the breath sounds, they're all normal. Okay. So if you do not aspirate it, if you do not auscultate and you do not check it, you will miss until the patient becomes very ill. So you should not wait. The idea is to pick them up before they drop their saturation, before they have, a straining of the accessory muscles of respiration. Before that, you must be able to pick it up. Okay, what are the signs in the chest that you would be thinking about?
So, whether the air entry is equal on both sides or not.
Okay,
Sir.
all right.
And, any like any added sounds like
Vesicular
yes, sir.
or otherwise.
Yes, sir.
Okay. If so, which segment has the difficulty? Which area of the chest has the difficulty? All right. What do you do after that? If there is a problem that you find, there's something unusual in the chest. No trick, man. What do you do in the ward? You're the resident seeing the patient. What would you do?
I like chest X-ray.
Okay, read this chest X-ray.
Sir, this is
This is a patient who was a second post-op day right hemicolectomy, laparoscopic assisted.
okay, sir. Sir, this is chest X-ray. AP view, sir. Sir, posterior anterior view.
Yeah, go on.
So yes, sir. For showing both the clavicles and the trachea in the midline, and there is a haziness on the left side of costophrenic angle, sir.
Okay. Only costophrenic angle?
Extending to the middle lobe also.
Okay. Do you call
Yes,
it the middle lobe on an X-ray or what do you call it?
No, sir.
You call it the zones,
Yes,
right?
sir.
Yeah, you have the
Yes,
upper,
yes.
middle and lower zones on when you read your chest X-ray.
Yes,
So
sir.
left costophrenic angle is obliterated, I agree. And there is a haziness, irregular haziness. What is the shape of that haziness?
So irregular.
Yeah, it's a bit irregular. Is it
Bit-
a bit triangular? Are you seeing my
Yes, sir. Yes, sir.
is it like this? Okay, a kind of
Yes, sir.
a segment there. What am I
Yes, sir.
getting at? So what are the possibilities here?
Maybe any atelectasis.
Yeah, atelectasis, will it give you such a nice classical distribution of opacity? It doesn't.
No.
It'll be a little more diffuse. It's probably pneumonia already coming in there.
Okay.
What is the other possibility? If I talk about a wedge-shaped opacity, it's not a classical wedge, but if it is a wedge, what am I looking at? Pulmonary embolism.
Pulmonary embolism.
Okay, embolism.
Yes.
This patient, as it turned out, had a chest infection, not an embolism, and we treated him with physiotherapy and antibiotics, and he got well. Okay, and I think Akhil has early change IVC assessment. Yes, I do not disagree with that, Akhil, but that needs expertise and further investigation. I'm only talking about clinical assessment as you go into a ward or an emergency department. So yes, if you're looking at the fluid status, IVC assessment is not wrong. But my focus when I was discussing was to just tickle all of you about the clinical assessment of a patient and things that should make you raise your antenna. In the abdominal examination, what are you looking at? Indraja, go on.
Yes, sir. Yeah, sir. Abdominal examination, whether any distension is there or not.
Mhm.
First, if any dressing is there, any soakage of the dressing.
Yes.
If any drain is present, how much is it is draining?
Yes.
Whether and bowel sounds are there or not, sir.
Okay. How reliable is your examination finding of, say, guarding and rigidity to indicate that there is something wrong in the abdomen in a post-op scenario? Reliable, not reliable?
Sir, it is reliable, sir.
Not reliable. Please remember that. You may have a major abdominal leak, excuse me, and there may be no guarding or rigidity. All right. And so do not go by the classical pre-op situation of guarding and rigidity to diagnose abdominal sepsis or an abdominal catastrophe. The patient has tremendous amount of pain, needing a lot of narcotic analgesics for control. And you go and you find that the abdomen is a little distended. There are no masses and it is really reasonably soft and there is no guarding or rigidity. Is the patient faking it or is there something else that's going on? Vinod.
Sir, I suspect paralytic ileus in the first, sir.
Ileus gives you tremendous pain?
No.
Intestinal obstruction, I can understand. Dynamic obstruction. Ileus doesn't give you a lot of pain. It may give you discomfort with distension.
Yes, sir.
So, any particular type of abdominal, bowel obstruction that you're worried about when the tremendous pain is there? It applies to a pre-op situation also post-op.
Adhesion.
Yeah, a lot of pain, little pain, I can understand. Akhil, you want to take that? Where are you from, Akhil?
The KMC Manipal, sir.
Very nice. So you want to take that question? If there is somebody who has a lot of pain and has minimal abdominal signs, are you happy as a resident or something you're worried about?
Mesenteric ischemia, sir.
Excellent. It suggests ischemia of the bowel. So what are the criteria on the ward that will, and in your simple laboratory criteria that will tell you that it's probably ischemia?
Serum lactate will be elevated, sir.
Yes, more than that, there'll be tachycardic. Okay, they'll be
Yes.
very tachycardic, 120, 130, and things like that. And yes, you mentioned lactate. One more thing that you really very easily available. What do you think their white cell count will be?
Elevated.
Very elevated, 20, 25,000, 30,000, things like that. Ischemia causes a very, very big neutrophilic response. And so you should look at possible tachycardia. The need for a lot of analgesia itself is a thing that should put your antenna up. Okay, don't dismiss it as an overreactive patient, and check the lactate and check the white cell count, and if they are high, then proceed to some kind of a higher investigation like a CT angiogram or an actual angiogram or something like that. That's outside the purview of this discussion. Okay, so please remember that a routine post-op ward is routine and good when followed with diligence and discipline. Ravi, comments? Sorry, no comments? Ravi, did you hear me? All right,
Yeah.
maybe.
Okay. Yeah.
Yeah.
I had to unmute myself.
All right.
I
Please.
think all the points that you've said is correct. I think it's important to follow that diligently. That is the main thing.
All right. So, do we have any other guests apart from our group here? Let me. Who is Kiosk iPhone? Please tell me your name. I'll rename you. Kiosk's iPhone. Lokesh, can you unmute yourself and take this question? You have a right hemicolectomy patient. Sorry, left hemicolectomy, 5th post-op day, has fever, breathlessness, and abdominal distension. So, Lokesh, where are you from? Introduce yourself, please. And are you there? Hello? Okay, I can't seem to reach him. Who else? Kiosk's iPhone. Who is this, please? Can you unmute yourself and tell me? It's good that even though we are online, that we know each other. You can even, get your video going if you have a reasonable bandwidth. Kiosk's iPhone. Who is this, please? Okay, you want to be anonymous or you're not there at all. I wanted to give a chance to all the people who are attending, even though they're not from the Sagar group, but doesn't seem to work. All right. Vinod, please take this.
Yes, sir.
This patient, 5th post-op hemicolectomy, left hemicolectomy, fever, breathlessness, abdominal distension. It is just again a summary of what we have discussed so far. I just want to see how quickly your mind works and you have a checklist of what you need to do. Okay, give me a differential diagnosis. I'll be more direct in the way I ask you questions. It should really not be this kind of a direct question. So what is your differential diagnosis in this?
One is anastomotic leak, sir. And the
Yes, yes, list them, yeah.
And there may be any fluid collected in the abdomen.
Okay.
And there might be, which might be infected.
Yeah.
Like pelvic or
give me a list. It's the same thing. In fact, leak and fluid collection are the same. Yeah, go on. There may be pneumonia.
Yes, pneumonia.
There may be DVT.
DVT.
These are the main things that you think of. Why would you get an abdominal distension in a DVT? Anybody else? Abdominal distension occurs because of gaseous distension. There can be with the
embolization.
Yeah, there may be pulmonary embolism, overbreathing. Half of the gas goes into the lung, other half goes into the tummy. So they get a gaseous distension. That's why they can get all this. Okay. So you now have 3 main things: anastomotic leak, pneumonia, and DVT. So what else would you ask for? And what would your focus on clinical examination be? Please remember that when somebody has these set of symptoms, they are the subjective ones. And then you have to have an objective assessment. This is where that comes in your SOAP. Okay, some of them will be obvious, which you see, and others you seek. You have to look for them. So what else would you ask for in this patient?
Investigation, sir.
Even questions wise, yeah. Say you go see a patient, he's breathless, he has fever, and there's abdominal distension. What else would you ask? Both in terms of talking to the patient and investigate everything. Yeah. As you see, the tests come later. I'm asking what else would you ask for? History wise.
Lower limb pain.
Yes, go on quickly.
Yes, sir. Lower limb pain and
abdominal pain.
Yes, sir.
We told you 3 main things, right? Chest infection, DVT, anastomotic leak. So abdominal pain, chest pain, cough, lower limb pain, lower limb distension. Yes. These are the questions that you ask for. And in your examination, what would be the focus?
Respiratory rate, I'll go for...
yes, respiratory rate, percussion of the chest.
Auscultation.
Auscultation to look for added breath sounds or limited breath sounds. Okay. Abdominal examination for distension. You do look for tenderness, if any, but as we mentioned, don't completely depend on it.
Yes.
Clinical examination of DVT, unilateral swelling, Homan sign, all right, and any kind of calf tenderness. So that is as for clinical examination. What else would you do in terms of tests?
I'll go for a chest X-ray, sir.
Yes.
And
Keep saying chest X-ray. Yeah.
chest X-ray, one CBC,
Yeah.
and a Doppler.
Okay. Venous Doppler. Good.
And one,
Abdominal ultrasound.
yes, sir.
And if you find free fluid, what else would you do? What is the best way to detect or rule out an anastomotic leak? Indraja.
CT,
Yeah. What did you say?
CT with contrast, oral contrast.
Oral contrast, left hemicolectomy. Anastomosis will be between the rectum and the descending colon or the transverse colon. When will the oral contrast reach him?
We'll give through analysis, sir.
Rectal contrast.
Rectal
What
contrast.
contrast would you use? Nikita. No, you don't know. Say you don't know. Let's not have silences. Are you there, Nikita? All right, Indraja.
I'm not sure. Yes.
Not sure? Never
Mm.
forget this. Any kind of GI leak, all right? GI leak that is suspected, never use barium.
Okay, yes, sir.
Barium peritonitis is devastating, all right? It can sometimes be fatal. And if you want to clear it, I've had the misfortune of having to do a laparotomy long ago for a barium peritonitis. Everything is so stuck, like sticky and stuck, that it's very difficult to clean it out. Okay. It must always be a water soluble contrast. All right. And it's a rectal contrast. So when you're suspecting an anastomotic leak or a perf DU, for example, when you want to give an oral contrast to look for a leak, always make sure that you use a water soluble contrast. Okay. So that is what you need to do. So, I have a lot of material, but we'll stop at 1 hour. It's really not nice for either of us to go on for long. You won't register it. We can have more sessions if required later. So I want somebody, we have Manisha, who is a resident at SHRC, joining as well. Why don't you take this, Manisha? What is this tube? And you have all the questions. Answer them one by one.
That's the Riles tube or nasogastric tube.
Okay. When would you use it?
I would use it
You
in
must
case
have seen it in the wards, no? Yeah.
if the person has, yeah. In case of an intestinal obstruction,
Okay.
to relieve the contents of the.
Right.
But it's inadvisable to use in case of ingestion of corrosives because.
Yes. Agreed.
And
yeah, it's down there. When would you not use it is another question down there. But yeah, focus on when you would use it. Intestinal obstruction. You've seen it. You've seen it in many post-op patients. There'll be a Riles tube put in. We'll talk about it a little more later. So sometimes used in post-op situations. When else can you use it? Nikita.
Sir,
Go on. Uses of a Riles tube.
sir, first one, for decompression, we can use it,
Yeah,
sir.
don't repeat what's been said. Anything to add?
I just joined now, sir. I'm sorry, sir.
I thought you were there. Something happened.
In the sir, I'm on call today, sir.
Okay.
I just had to log out and log in again.
All right. Okay. What are the rules? Okay. Riles tube, what has been mentioned is in a post-op situation, and to decompress it in intestinal obstruction. Where else can you use it? Have you used it to feed
To
people?
RT feeds.
Yeah,
Yes, sir.
RT
RT feeds.
feeds is something that we keep talking about. What are its advantages and disadvantages?
Advantages, it directly bypasses the and
It's easily available.
yes, sir.
It's cheap. Relatively easy to put in. Okay. What else?
Yes, sir. Customizable.
Yeah.
And
And generally easily managed. Doesn't need a lot of tech, expertise to manage a Riles tube.
yes,
Right?
sir.
What are its disadvantages?
For a patient personally, it is a
Very uncomfortable thing. Very good.
yes, sir.
Very uncomfortable. Very good. Because unless it is absolutely required, do not use a Riles tube. Go on.
It could be misplaced, sir. I mean,
Yes. Yes.
initially, it's a skill.
So you may put
wrong
it
skill.
elsewhere and you put some food into somebody's
Okay.
lung. Yeah. Okay.
Yes, sir.
Okay. What else? You can put it in the wrong place. Even if you put it in the right place, it can go to the wrong place.
Go to wrong place.
That's called a misplacement versus a displacement.
Yes,
Okay.
sir.
Putting it in the wrong place is a misplacement. Being in the right place and then going to the wrong place because of movement or vomiting or coughing or whatever is a displacement. All right. Then what are the other disadvantages? Vinod.
No, I'm not.
Yeah, go on. Vinod.
Sir, it may lead to aspiration, sir.
Very good. Why does it lead to aspiration? Very good.
If the patient is if it comes into the if it displaces and it may come into the esophagus.
Even if it's in the right place, it increases the chance of aspiration.
Of aspiration. Yes.
Why? You see, we use the Riles tube so often and so commonly, and all of us we are not actually freshers. Even as undergraduates, you would have seen. So it means that we haven't really understood it. So
OG junction.
Yeah, good. What happens to OG junction?
Actually, it will be in opening position because of the.
Yes, you are artificially keeping it patent. With the tube going through, LES cannot work even if it's competent, and so they can aspirate.
Yes.
Okay, and what else does it do? Does it do anything to the stomach?
Chances for bleeding, sir, because of mucus.
Why? Yeah, lot of erosions. It can cause a lot of damage to the mucosa. I'll show you some pictures after this, which is Riles tube induced. It can cause a lot of damage to the mucosa. So these are the disadvantages. So how would you make sure that all this is minimized? I can't say you can completely eliminate it. How would you minimize these issues? In other words, what are the precautions that you take when you put it in?
I'll be sure that it should be in the right place so that.
How do you even put it in? What is the best way to put a Riles tube in?
Sitting with a flex neck.
Okay. Patient is sitting, you give him instructions, and what do? How do you make sure to the best possible extent that it won't go into the lungs? You give them a swallow of water, okay? Ask him to keep it in the mouth and ask him to swallow it when you ask him to swallow it, when you order it. Give him a trial run once. Give him a little bit of a sip of water. Ask him to hold it in the mouth and say, swallow it now, and he'll swallow it. Next, give him another swig of water. And as you ask him to swallow, as he is swallowing, you push the tube in.
Yes, sir.
So that nature would have closed the epiglottis in his endeavor to swallow, and hopefully your tube goes into the right place. And how do you check that it is in the right place?
One is aspiration, sir.
Yes.
Content aspiration, and
right.
One is giving a gas and checking the
epigastrium. Yeah. Between the two, which is you think preferable?
Sir, easy way is best way is aspirating content, sir.
No, you can get aspiration even if it's in the lower end of the esophagus.
Okay, sir.
So if it is in the stomach, it's better. And of course, the best way, most reliable.
pH.
No, get an X-ray.
Okay,
Make
yes,
sure
sir.
that the tip, which is radio opaque, is inside the stomach. Okay, these are the three things. Now, when would you not use it? Indraja. Manisha mentioned one already.
In case of any facial traumas.
Yes,
Yes.
particularly nose
Nose.
and the face. If you
Yes.
suspect a kind of nasal fractures, skull base fractures and the like, you do not even attempt it. And she also mentioned the corrosive intake. If it's
Yes.
very mild and the patient is not very ill, you can put it in, but you don't have to. Much better to do an endoscopy, even in the acute phase. But generally, if you suspect significant corrosive poisoning, you would not put a Ryle's tube in. All right. What are the alternative uses apart from putting it from the nose into the stomach? Go on. Why are you so quiet, Indraja?
Yes. Yes.
Akhil still there? Akhil, you want to take it? I
We
think
can use it for feeding jejunostomy, sir.
yes, feeding jejunostomy. Yeah. Anything else?
We can use it in pediatrics as a drain, sir.
Okay.
We can
Even
use it
even in adults, it's not wrong to even
negative
okay.
pressure therapy. We can use it, sir.
Yes. Yes. Good. Yeah. I think that's good enough. Okay. I've said here, what is TEF?
Tracheoesophageal
Tracheoesophageal.
Fistula. Huh? Okay. That's okay. Yeah. Okay. So we have sort of answered all this, and I'll show you some pictures to explain these things. Okay. And this is actually induced by Ryle's tube. Can you see these erosions? It's as if this patient has multiple erosions and ulcers of the stomach. You could easily mistake this for very severe ulcerative antral gastritis, but it's actually Ryle's tube. And if you have other pictures, if I had shown you of the same patient, if you do a J, you can see a lot of these ulcers in the body and fundus as well. And this is something which is one of our patients. What's happened here, Nikita? I'm not asking you to guess too much. What's happened there? The red ring. Praveen.
Erosion of the mucosal layers.
Is it erosion? Is it mucosa?
I think
Is it a pressure sore? Huh?
Yeah, it's a pressure necrosis. Okay, so all the problems that you would have, displacement, blockage. I mentioned the gastric ulceration. The same ulcers can bleed. You can have aspiration, and this is it, alar nasi necrosis. This is a patient who actually had the Ryle's tube for only 4 days. It was not even that he had it for weeks on end. But I think for fear of the Ryle's tube coming out, it was so severely stuck with a plaster that the patient got necrosis. Okay. What are the other uses I mentioned? This is a feeding jejunostomy. It is an extremely important thing for surgeons to remember. Whenever an operation, major operation is done, head and neck, chest, esophagus, pancreas, liver resection, major bowel resection, always put a feeding jejunostomy in. I think it's a very, very important trick to have. And if you're doing a gastrojejunostomy, you put a nasogastric tube, push the nasogastric tube across the gastrojejunostomy and put it into the jejunum, the efferent loop of the jejunum. That can be used for feeding in the first few days. Okay. And it can be a stent or a guide during OG junction surgery. It was not mentioned by Akhil, but this is one of them which is very, very important. You can put a big Ryle's tube when you're doing operations in the hiatus at the OG junction, including your fundoplication, for example. It'll be a guide to you, and inadvertently, if you get into the esophagus, you will know, because you will be seeing the Ryle's tube. I hope it never happens to any of us. Hasn't happened to me so far, God forbid. You can also use it as a stent in a hepatico-biliary surgery. You can put you may have a hepatico-jejunostomy, and you can use a Ryle's tube as a stent across it. And as I said, feeding jejunostomy, I mentioned the stent in the biliary tree, and it has many, many uses. The Ryle's tube, the simple Ryle's tube has many uses. So we mentioned about the problems of a Ryle's tube. So we will discuss the alternative to a Ryle's tube and then close this class today. And I have a lot more things like this, and we'll do it on another day. So, Vinod, you want to take this? I've even given you a hint in the picture on the right of the screen. What is this that we're trying to do? To get over some of the disadvantages of a Ryle's tube. Describe what you see. It is an endoscopic picture. Describe what you see on the picture.
A tube, sir.
Yes. The
Coming
blue
from-
thing is a tube, and there is something coming out of the tube. What is this part? It's an upper GI endoscopy. What organ are we in? There are only 3 organs: esophagus, stomach, and duodenum. What do you think this is?
Duodenum, sir.
Will it be this big?
Sir, rugae is not there. Stomach.
Rugae is not. Why is it not there? It's a very important point. I'm glad you noticed. It's a very big, capacious organ. In the upper
Gas-
GI tract, it is the stomach and nothing else. It is grossly distended, deliberately so.
Because
So
of gas.
Yes, we have put gas in and distended it. And that's why rugae have become flattened. So this is a tube into the stomach and a thread that's coming through it. What is it a part of? What am I doing here? Yes, we're doing a PEG. So PEG is an alternative to, excuse me, the Ryle's tube. And this is what we do. We put an endoscope, distend the stomach. It comes up against the abdominal wall. We stick one of those plastic trocars into it, plastic tube, put a thread through it, a loop of thread, and catch it with a biopsy forceps or a grabber, take it out of the mouth, attach the back end of the PEG tube to this tube and pull it out of the abdomen. And you have a flange on the inside which pulls the stomach up and keeps it up against the abdominal wall. Okay, that is a PEG. All right. And so having put, this is what the PEG looks like from the outside. It's a tube that's coming out of the epigastrium, and there's a flange which holds it snugly against the against the abdominal wall, against the skin of the abdominal wall. So who will take this? Praveen, is it too much for you? Probably would never have seen a PEG. Okay, Pawan, take this, man. What do you do? How do you maintain a PEG?
Sir, after every feed, we will give and wash, sir, with
Yes.
plain normal saline.
Very
Or
good.
if it is
Before and
completely blocked,
after. Before and after every feed to prevent blockage. Good. Next.
and if it is a complete block, we'll try with some bicarbonate.
Yes, with an aerated solution. Good.
Yes, sir.
Yeah. Okay. But the point is that you should not let it block. Yeah.
Yes, sir.
We've got one answer here. What do I mean by a snug tube? You can see this is called the flange, the white thing. It's
Yes,
sort of sitting up semi-vertical from the abdominal wall, from the skin. And the tube is straight out. This should not be sitting lax. There should be no movement between the tube and the abdominal wall. If this flange is not holding it snug against the skin, then the tube keeps moving and that hole becomes bigger and it leaks. Difficult to manage that. So you must always pull the tube up gently, not too hard, and push the flange down at least 2 or 3 times a day so that the tube is snug against the abdominal wall. Cleaning you have mentioned, flushing you have mentioned, particularly before and after a formula. Okay, so we mentioned one of the uses of the Ryle's tube to be in the post-op phase. All right, Indraja, why would anybody use a Ryle's tube in the post-op phase?
Sir, if post-operatively, gastroparesis will be more, sir.
Okay.
So we should decompress.
So what
the
happens? So what happens if there's gastroparesis? How is it bad for the patient? There's an acute gastric dilatation. That's what surgeons are afraid of. How do you detect an acute gastric dilatation?
Patient
Have,
will have
have you, yeah, go
yes,
on.
sir. Have distensions, abdominal
Yes,
distension,
yes.
and yes, sir.
Breathlessness because of this
Breathless.
huge distension pressing against the diaphragm.
Yes, sir.
Diaphragm gets stimulated, so they may even have hiccups.
Yes.
Hiccups, breathlessness, distension, nausea and vomiting. They may
Vomiting.
actually vomit also. Above all, because there is 2 or 3 liters of fluid in the stomach, what happens? They become hypovolemic. They become sweaty and they may even drop their blood pressure. But does it happen often is the question. So often that you have to put a Ryle's tube for prophylaxis. What's the answer? How often have you seen a Ryle's tube being put in a post-op patient in Saga?
Sir, generally we'll use for major abdominal surgeries, sir.
Okay, like what?
Like a resection anastomosis,
Okay,
or major laparotomies.
okay.
And
Would you do it for a gallbladder?
no, sir. Generally,
Hernia?
we'll place during surgery. After that, we'll remove, sir.
Okay. All right. So what is, Pawan, what is your take on the routine use of NG tube after an operation, even a major operation? Let's say hemicolectomy.
Sir, hemicolectomy, sir, no need of Ryle's tube, I'm thinking.
You think, why do you think so?
Sir, because contents, most of the contents won't come through the Ryle's tube, it won't drain. And the Ryle's tube
It
is
will come through. It will come through. But the actual reason is something else. You don't use it routinely, but the reason is something else. You see, these are the things. Apart from a gastric ileus, you're thinking by decompressing it, you will reduce pulmonary complications, aspiration, risk of anastomotic leakage. People thought that would be less, and increase patient comfort and shorten hospital stay. People really thought that. But what is the reality?
ERAs, sir, we won't.
Yeah, you're talking about ERAs. That's right. So you have, you must have evidence for everything, as I keep saying. Evidence in about 5,700 patients, routine use 2,500 patients, more than that, randomized between routine use and no use. And it's very clearly say that none of the intended advantages holds true with a Ryle's tube. So it should be abandoned in favor of selective use of nasogastric tube. So what would that selection mean to you straight away? If somebody is operated for intestinal obstruction, when you know that there are huge gastric aspirates, after you have relieved the obstruction, it's not going to get better immediately. Okay? So you need to decompress it. That's one of the common things that you would think of. And if you have had a situation where you have a gastric anastomosis, which you would like to protect, as it were, stomach operation itself. And as I also said, after a GJ, for example, you want to use a Ryle's tube to put it beyond the anastomosis as a feeding tube from the first post-op day. These are common situations where you would use an nasogastric tube. But by and large, you do not need a nasogastric tube. Okay? So this will be the last part. I'll take this and then stop. Otherwise I can keep on going. Not using a nasogastric tube is an integral part of ERAS. Okay, Akhil, educate us on ERAS.
So it's enhanced recovery after surgery, sir.
Yes.
It has pre-op component, intra-op component, and post-op components.
Excellent. Go on.
Pre-op will educate the patient, will try to reduce the period of nil paroral, and will give carbohydrate-rich drink.
Right.
Will give thromboprophylaxis.
Yes. Excellent. You're doing well. Go on.
We'll give a rehabilitation, sir.
You already gone to, there is an intra-op component. There are many things in the intra-op component, but you're doing very well.
Intra-op will prevent hypothermia, sir.
Okay.
And maintain fluids.
Yeah.
And
Yeah, the main thing is do not overload with fluids. Do not give them opioids, even in the intra-op. Use laparoscopy as much as possible, and do not be very liberal with your blood transfusions. Okay, that's the intra-op. And in the post-op period, early mobilization, removal of tubes and drains. We'll talk about tubes and drains some other day. Early oral feeding, very, very important. If you do these three things very clearly, better outcomes have been documented in many, many kinds of surgeries. It started with colorectal surgery, and it has been useful in many other surgeries as well. Okay, I think I will stop here today, and I invite comments and critique. Don't hesitate. Critique from everybody, starting from the junior most. Nikita. What is a critique, Nikita? Are you there, or are you on call somewhere busy? Maybe she's not there. Praveen.
Sir, any
What is a
contraindications
critique?
to the statement, sir?
What is a critique? We
Uh,
keep talking about in journal clubs, no? You already attended one or two.
yes, sir.
Hmm.
Any contraindications to the given statement?
Contraindicate? No.
Not contracting to the statements.
No. A critique is the good points and the not so good points of a given presentation. So your critique. Don't worry, I'll not get upset if you say your class was hopeless, sir. Yeah, go on.
No, sir. Actually, I have learned a lot, sir.
You learned a lot.
From the
Okay.
basics. Yes,
What could have been better?
no, sir. All was good, sir.
All was good.
From
All
my
right.
side. Yes, sir.
Next, Vinod.
Yes, sir. My perception in the rooms has changed now.
You change now. Good. All right. Indraja.
Yes, sir. The class is very informative, sir.
Yeah.
Generally, we'll miss most of the things while doing
Right.
rounds.
Yeah.
So we have to
Excuse me.
change from
Yeah.
there.
What I've done is sabotaged Pawan's work. All right. But it doesn't matter. You will, if you see Pawan's project for this year, it is about this. And
Okay.
anyway, it doesn't matter. I hope you guys take what we have learned today seriously and follow it verbatim, follow it seriously in the ward. Okay,
Yes,
Abdul.
okay, sir.
Sir, what we practice in our hospital is upper, like stomach and small intestine, we put a Riles tube.
Okay.
For colon, we don't put a Riles tubes.
Right.
Colonic surgeries.
All right.
And for hysterectomies, all that we don't put the Riles tube. So
Right.
it was quite informative. With
Yeah.
the class was quite informative, and I learned a lot about it.
Yeah, I think we should. I have, this can go on for another hour actually, and so we will schedule another ward round maybe next month. Okay, and
Yes, sir.
and then discuss further things about drains and so many other things that we, all evidence based, and we'll discuss that later. Final
Sir,
comments. Yeah, go
I had
on.
question of
Go on.
police, sir.
Yeah, we'll talk about it later. It comes
Okay,
later.
sure.
We'll talk about it later. Yeah, it comes later. Yeah. Okay, Ravi, your final comments, and we'll close the class.
I think, sir, I think it will be not correct for me to comment on slides.
Please do it.
Because they're all fine. I know, obviously, you are teaching people how to do it, so you obviously do it the right way. So just to reiterate, I think students note that how slides are, arranged, and also, diagrams, and see in between, to keep your interest going. So I think whenever you are presenting, you have to understand that you have to hold the audience for a considerable period of time. So there should be interlude where you bring in pictures and slides, which depict what you are supposed to do. So I think that sir has followed that principle. Second thing is reiteration of the basic fundamental principles in the post-operative management. I think it is good to keep on, strengthening and reiterating what we know, because there is tendency to forget sometimes. So I think this class has achieved that.
Thank you. Thank you very much, everybody, and good night.
Good night, sir. Thank you.
Good night, sir.